Well, mine's luckily not that scary, and I think it's pretty straightforward. I think all of us will probably see this kind of a complication. So it's actually one of my partner's case that I kind of walked into. It was a 68-year-old female. She was it was great. So I love the first talk. I was just walking by, and so I peeked into the room. It was quite a large person. BMI was 40, and she had a left foot wound, and she's just getting an intervention done. Here are the images. This is post-intervention. She had a heel also. The posterior tibial artery was diseased, and it was opened up. And I just walked by, and then the next thing I know, they're calling me in the PACU. Well, I was probably just walking by. So 30 minutes post-procedure in the PACU, her blood pressure is 50. So what would you guys do? And she's writhing in pain. We eventually got her H&H. Probably came back a little bit later, but 11:33, and then post-procedure was 7. So any ideas? Scanner, and there was some concern that there was some difficulty going up and over the bifurcation. I wasn't around for that, but there was some, just like we talked about, they said there was a little bit of a struggle going up and over the bifurcation. So what would you guys do? Scan this patient?
It's amenable within a few minutes?
Not really. I mean, I think you have to move this patient. She's unstable, yes, and so it's a little bit trickier. And we're right in the PACU, so we're right next to the door.
Let's go Andrew.
Yeah, I mean, I think it's pretty serious. So, take her for an angiogram. The aortogram looks okay. And then when I looked at the films from previously, I thought the stick looked a little bit on the high side, and so pretty straightforward complication. I mean, she had a bleeding, she had a pseudoaneurysm. This was closed with an angioceal. It was a 6 French. It was closed with an angioceal, but maybe there was failure of the device. And you can see the femoral head. Can you see my area? The femoral head's here, so it's a little bit on the high side, and that's what I noticed on the first run too. So again, straightforward, little Viabon. We put an 8 millimeter Viabon, and she did great. So it's a fairly straightforward complication for us. I think this is something that everyone will see, and it was just whether we should scan her or not. Was an aortoiliac injury or not, because that was a history that we had, and I was concerned. If it's an aortoiliac injury, then we need to be ready to stent it or put in an endologics device, especially with the narrow aorta. That may be the best way to get out of that kind of trouble. So that's it, guys.
Would you think about coiling it, right?
So I think my options would have been just cut down on her, right? I mean, you could try and coil it. I think that's reasonable. It might take a little bit longer time to potentially. I mean, putting a Viabon in takes a few seconds right there. I mean, it's not the most optimal, but it was in the external iliac. I understand that, putting in the common femoral, but for morbidly obese and then trying to coil it, and she's hemodynamically unstable, I think probably looking at a more definitive repair. Cut down would have worked, but again, she's big person. I mean, it's not an emergency cut down. You're going to end up with wound complications, groin complications. We've all been there. Those kind of procedures drag on. So for this kind of patient, I think she doesn't have a big hematoma on the skin where you're compelled to do that, right? I mean, sometimes you have this large femoral hematoma that that's the better way. Otherwise, the skin's going to necrose. But for retroperitoneal hemorrhage, I think this is probably better. I mean, would anybody coil this?
No, coiling would be tough because that artery.
It's also just a free space. So where does it sit? Actually, exactly. Yeah, where is it going to sit?
Even like a balloon tamponade?
But you don't think that epigastric was involved?
I don't think so. It looked a little like half a centimeter below that, because when I looked at the previous, so what I do, every time I stick, I actually take a fluoro spot of my stick. I don't know if you guys do that or not, so that in case something like this were to happen, I know where my stick is. So my practice is, under ultrasound guidance, under fluoroscopy, I stick, and just with the needle, I mark it. I save an image for later on. In case the patient bleeds or something, at least I have an idea. Okay, this is where my stick was high. Okay, so this is what's really going on. And embolization?
No, when we thought it was, when we thought that it was just a free flow, and the epigastric was involved, we put the cover center across, she kept getting out the center.
Then you have to embolize.
Retrograde bleeding to the inferior epigastric, we had to come all the way down and coil that. So in these kind of cases, I think you got to take at least a selective shot at the epigastric.
And actually, that's the problem I had in a case where I was doing a lytic patient and my glide wire perfed one of the branches.
Yeah.
So the Viabon didn't do the trick, so I had to come from up and over, and I ended up.
Well, I think if you're coming up, so that was a control out, up and over, and then you had to bleed on the other side.
And no,
without-
I was coming up and I was fixing the right acute leg, and I had a perforation, which is basically through the inferior epigastric artery. We put a wire band there,
Yeah.
and then we
Yeah,
ended
that
up
won't work.
finding more collaterals feeding this perf.
Yeah.
And this patient was analytic with a occluded leg. So after that, I've learned that, take selective pitches because those iliacs communicate with each other. Plenty.
Absolutely.
Yeah. But I'm glad she did well.
What's that?
You know that better than
Yeah. I mean, absolutely. I think that, again, our technique of sticking, I think with ultrasound, it's a little bit less like you'll hit the epigastric. I think you might be on the higher side, but I don't think you'll be more medial or lateral or circumflex, any of these things. Yes, Evan.
I was just going to say, I had a similar case where trainee used a closure device, nothing coming out from the skin, but the patient drops the pressure.
Correct.
Thank you. And so using closures, you can seal the tract, but the bleeding can happen internally retroperitoneum. And so you
Yeah, and you'll never know. I mean, I think this is an important thing for all the fellows and all. I mean, this is, post-procedure hypertension is an RP bleed until proven otherwise. You hang blood, and I think you just have to, go the fastest route. I mean, imaging probably won't add anything here, unless you think something catastrophic happened, like that case was catastrophic. That's a very different story. But otherwise, I think just rush them back to the endo suite, and or if it needs a surgical repair, then so be it. Thank you.